We just finished a voting session. Now we are having a briefing. It is January 24th, 12:33 p.m. Welcome to the Health and Government Operations Committee. Today we're having a briefing from the Maryland Community Health Resources Commission on health equity resource communities. And we have Mark Lochner, the Executive Director, Nellie Washington, the HERC Project Director, Liz Kruger, who is the Director of Homeless Services, Interfaith Works, and Jolanda Obolu, who is the HERC, she's a HERC grantee as well. Are we bringing everyone up? Sure, why don't you just come up? Yes, please, thank you. You can all come up and bring some chairs. Thank you so much for the flexibility. And it's wonderful to see you all. Ms. Ortiz, nice to see you. And good afternoon. How's everyone doing? Happy New Year.
Happy New Year.
Welcome to the Health and Government Operations Committee.
Thank you.
You're most welcome. Who would like to get started?
If I can start, Madam Chair.
Yes.
Thanks again for the invitation. Mark Lochner, Maryland Community Health Resource Commission. You introduced everyone, so thanks for that. Don't have to worry about that. I'm going to kick things off, and then I'm going to turn things over to Nellie Washington, and then we're going to have our two grantees. They're our shining stars. We have a lot of shining stars, but we wanted to be, get two from different areas of the state. So we submitted written testimony to the committee, a PowerPoint, which I'll run through, and then also Nell prepared short paragraph summaries of the 12 HERC grants, which are under active implementation. You have that as well. Does that sound good?
Thank you. Sounds great.
Great. I just want to take a minute to thank the ongoing support of this committee. You approved our reauthorization legislation last session, so thank you for that. Really appreciate that. Thrilled to do the work. You have before you our list of 11 commissioners. I'd just like to take a moment to thank them for their service. I think what differentiates us from other folks in state government is we have this great group of 11 commissioners. They're very engaged. Many of you know them. Delegate Hill, I know you know Senator Casemar very well, so I want to give him a shout out, our chair. I'm not going to read the 11 names, but just great group of folks. They're diverse. They come from all areas of the state. They contribute their expertise, and it's just a privilege to support their work and take their advice. Let's go to the next slide.
On our behalf, thank you for the work you guys do. You do good work. Thank you.
Thank you. Okay, so we have three funding programs. We have our annual operating grants that we award, as you would imagine, once a year. That's $7 million that gets distributed to underserved communities. We added there the three bills that have been approved by this commission, by your committee. Thanks again for last year's bill. That middle bill, I just wanted to make, in 2014, the sponsor was Mr. Public Health, right? I just want to take a minute to recognize Jim Hubbard, so thanks for that. We're going to talk about the Health Equity Resource Community Act, which Nell Washington leads in our shop. That was introduced, you'll recall, by Delegate Jazz Lewis, and it's a 7-year program that Nell will talk about in a minute. And then we also have the Consortium on Coordinating Community Supports, which is part of the Blueprint Bill. At another time, Madam Chair, if you'd like to hear more about those grants, happy to tell you about those. These are our three funding opportunities. And not on the slide, I see your Vice Chair is not sitting here, but I just want to thank her for her leadership on school-based health centers. We're happy to staff that council.
We have Delegate Olson, Delegate Collison, Delegate Kipke are actually excused, and Martinez, they're actually have some things they had to take care of, but they're listening. Some of them are listening.
Great. Well, I just want to give a shout out to Vice Chair of School-based health centers. Let's go to the next slide. So over the years, and this coming May, Madam Chair, we are going to be celebrating our 20-year anniversary. 20 years this coming May. And so over the years, we've awarded 866 grants, just under $300 million. We've been pleased to support programs in all 24 jurisdictions. 660,000 Marylanders have been served. 10% of the state has been served by the grants that we've been pleased to award. Some of the evidence of the impact, $45 million has been leveraged by our grantees. That's something we take very seriously. Our colleagues over in DBM hold us accountable. Also, the grants that we award, this is the key factor that we look at because they're highly competitive. 3/4 of our grants, 76% of them are sustained at least 1 year after the funding has been provided. That's something we really hang our hats on. We're also thrilled to be asked to be the public steward of these resources. So right now, we have over 200 open grants involving 210 million. So we take that very seriously, and we've got a real small shop, and we take that role of being a public steward of the public fisc very seriously. Let's go to the next slide. So thank you to this committee for giving us a great, we like to call it now, right, the legislative Bible here, the Health Equity Resource Act. 5 key objectives that this committee approved earlier: reduce health disparities, improve health outcomes, improve access to primary care, promote primary and secondary prevention services, and then to reduce healthcare costs. Just want to give a shout out to the sponsors, of course, Delegate Jazz Lewis and Senator Hayes in the Senate. Thanks for giving us a real clear legislative roadmap to follow as we implement this act and do the work with our grantees. Let's go to the next slide. So I also wanted to thank this committee. There were a couple of things when you all amended the bill that we asked for, and you gave us each of those things. So one of those things was a great group of advisory committee members. Great group of folks that serve and volunteer their time. We really rely on this expertise of the Health Equity Resource Advisory Committee. Let's go to the next slide. So this will probably come as no shock to those of you that know me. We organized pretty quickly into subcommittees. So one of the subcommittees was program and data evaluation. So I want to give a shout out to Chair Rebecca Altman. She had a conflict or she would be with us today. And then also Elizabeth Chung, our former chair at the commission, she volunteered, was appointed by the governor to be the chair of our consumer outreach and consumer engagement. I'm going to pass over here now in just one second. That second subcommittee is really important because we did significant outreach into the community, and many of you in this group were part of those outreach events. So thank you, Madam Chair. So check this out, right? A year ago, we went into how many jurisdictions now? Almost half the state, right?
Yeah.
Half the state, and with Nell's leadership and thanks to Chair Chung and a number of folks in the office, how many proposals?
59 proposals.
59 proposals requesting 290 million. That's staggering, right? And so we used that bi-directional outreach with these communities to make sure that they knew about this important funding opportunity, a landmark investment made by the General Assembly to improve public health and health outcomes in underserved communities. So we take that very seriously. I'm going to pause here and pass over to Nell, and thanks again for the invitation, Madam Chair.
Good afternoon again.
Good afternoon. Thank you all. So just to piggyback off where Mark left off, the Maryland Health Equity Resource Act, that legislation, funded programs for a 7-year term. And that term was divided into 2 phases. We have the 2-year Pathways to Health Equity pilot program that began in the summer of 2022 and ended last summer in June. And in that program, we awarded 9 grantees, $13.5 million to address health disparities, as well as social determinants of health needs across the state. That program served a great purpose, lots of lessons learned from it, but primarily it provided the grantees the programmatic foundation and support from our advisory committee, from our commissioners, to potentially apply and be funded for the longer 5-year HERC term. In that program, we're proud to say that we served over 11,000 Marylanders, and that, again, laid the foundation for the HERC phase to begin. Here we are in the HERC phase. That program began in the summer of 2024 and will stretch through to 2029, awarding 12 grantees, 2 amazing programs here with me today. $41.5 million to address chronic disease, mental health, as well as maternal and child health areas across the state. The special thing about our HERC effort is that there is a huge emphasis on ensuring that our grantees address those emerging SDOH needs and provide interventions accordingly, in alignment with that clinical care and care connections that they're making for our enrollees and participants. Once our grantees meet their goals of 49,743 individuals served, if you look back to what we achieved in Pathways, we would have served nearly over 60,000 Marylanders, and I'm pretty proud of that work. So this is just a snapshot of the geographic footprints of the 9 Pathways grantees. Again, a 2-year pilot program. You kind of see the stretch from Baltimore City all the way through to rural Maryland. We had 3 programs providing services, intervention activities in Baltimore City, 3 in Prince George's, and 3 in rural Maryland. And of note, 5 of the 9 grantees were also served in communities that were prior supported by the HEZ's Health Enterprise Zone initiatives. So you just kind of see that Pathways grantees touch geographically across the state. This is just a snapshot of what our CHRC HERC grant monitoring looks like. It's important that we not only provide our grantees with the support, the advisements of our commissioners and our HERC advisory board, HERC advisory committee, but also ensure that we as CHRC staff we have outlined requirements in terms of performance reporting, tracking, and grantee monitoring. And we do that on a quarterly basis. We do that on a semi-annual basis, as well as a year-end closeout for each year of the implementation period. And this is really important, especially when you're, working and managing the anticipated outcomes. So the Pathways clinical health disparity areas, these are just, again, a snapshot of some of those areas of address. Of course, chronic disease, diabetes was at the forefront of a lot of the interventions and our programmatic activities. Hypertension, heart disease, mental health, substance use disorder, maternal and child health, as well as sickle cell disease. And then you see in accordance the clinical outcomes for each. Some are standard, some are custom, but this just kind of gives you a flavor of what we were measuring in terms of what the program set out to achieve from a clinical standpoint. From a hospital utilization standpoint, this slide to us speaks volumes. This is the impact from a hospital utilization, the hospital visits, as well as healthcare cost of our 2-year Pathways program. And if I could just emphasize, the Pathways programs was 2 years, but it took we probably had about 6 to 7 months, Mark, of startup, challenges, things that we had to work through for our grantees. So they really got rolling probably within the 7th or 8th month for many of the programs.
Yes.
Yeah, so this is what was accomplished in under 2 years. So as mentioned, in terms of the folks that were served, over 11,000 Marylanders, there is an uptick in hospital visits, but you would expect that because we're connecting folks to care. But if you pay attention to the hospital charges, reduction or decline in hospital charges, ED visits, as well as ED charges and inpatient visits and inpatient charges, you see those declines were in double digits. And again, this was accomplished in about 13 or 14 months of programming. So we're pretty proud of that. Simply put, the programmatic work and our efforts, it's working. And we're going to do much more within the HERC phase, within the 5-year phase. At a glance, this is what our cohort looks like. We have a very diverse cohort. And as Mark mentioned, the outreach for the HERC RFP was intense and it was robust. And I thank all of the legislators who played such a large role in ensuring that everyone knew about the funding opportunity. The legislation required only 5 entities to serve as leads. FQHCs, CBOs, community-based organizations, academic, health departments, I'm missing one more, and nonprofit hospitals. I got it, Mark. And I'm really proud to say that all of those entities are represented here. So again, very diverse. And this is what the imprint of, or the footprint of HERCs looks like from a geographical standpoint. We went from, with Pathways, 6 jurisdictions to 11 with HERCs. Yep, statewide, and $41.5 million awarded. You see highlighted in purple those grantees that were previous Pathways grantees. So again, that's an opportunity to extend the work that they started in the Pathways phase. We have, 5 of the Pathways previous Pathways programs that are serving now as HERCs. So we added 7 new programs to the cohort. And here we have the social determinants of health areas that our HERC programs are addressing. In the RFP, we required that the applicants address a minimum of 3 of these areas. Many of our programs are addressing, well, the minimum of 3, of course. I think we only have 1 that's addressing 3, but most of them are around 5 to 8 of these areas. So transportation, food insecurity, housing support, health literacy, helping folks make and be informed when it comes to their decision making regarding their health, employment assistance, workforce development, the language interpret services, safety, legal assistance, and of course, Medicaid enrollment, insurance coverage. And this is at a glance some of our health disparity areas: chronic disease, diabetes, hypertension, obesity, sickle cell. And I don't want to steal the thunder of our amazing grantees. They're going to speak specifically as to what those interventions look like and what some anticipated outcomes are for the committee. But we have 4 grantees that are addressing specifically chronic diseases, and then many are addressing mental health and chronic disease. Many are addressing more than 1 clinical area. Regarding our HERC grantees that are addressing mental health disparities, substance use disorder, mental health support, behavioral health as well. And then another clinical area amongst our cohort is that maternal and child health disparities. So that includes, assisting our expecting moms, connecting them to prenatal care, connecting them to Medicaid, connecting them to WIC, and then managing their whatever chronic health conditions they may be dealing with as well, in addition to connecting all of these folks to those social needs, supports, resources, and linkages. So we are in month 7 of our implementation period, so we're very young in the infant stage, but we've had a lot of good accomplishments in the last 3 to 6 months. So again, firming up all of our agreements with our partners, our coalitions, data use agreements and such, the ongoing state support, technical assistance that Mark referenced with our Data and Evaluation Subcommittee chaired by Rebecca Altman. Partners with CRISP available to kind of work through whatever technical support or CRISP-related data support that our grantees may need. And of course, our internal team, small but mighty, as Mark calls us, who work collectively as well as individually with each grantee. Our grantees have hired all key staff, and their program doors are open. So the key activities and interventions have all been initiated. Ooh, I think I'm going forward.
Going backwards.
Backwards?
Try this.
Thank you. Thank you, Mark. So in this next 6 to 12 months, of course, we're going to continue with the technical assistance and support of our grantees, and then ongoing programmatic and fiscal monitoring by our CHRC team. But the biggest piece that is important now is that community outreach and program promotion. I think in the last 7 months, I've probably participated in over a dozen events, presentations where I'm spreading the word about our grant programs to enrollees, CBOs, faith-based organizations, legislators, associations, just to let them know, to let their respective communities know that these services, free services, are available and the doors are open. Again, I want to, not steal the thunder of our amazing grantees, but I'm going to give a warm handoff to Dr. Ogbulu, who's going to speak to her HERC, the Rich 2.0 program.
Sure. Thank you, everybody, and good afternoon. It's a great opportunity to talk to you about the West Baltimore RICH Collaborative. RICH stands for Reducing Inequities in Cardiovascular Health, and our focus is in a targeted area in West Baltimore. We have been on quite a bit of a journey in that the group of organizations that are collaborating on this project have been working together for many years and been dedicated to reducing health inequities in West Baltimore. Some of the organizations were part of the initial health equity zones, which was funded through legislation. And then we had the Pathways for Health Equity grant that we focused on reducing cardiovascular improving cardiovascular outcomes, as well as reducing social isolation in West Baltimore. And as was mentioned already, that grant was for 2 years. It took us about a few months to get started. But over the period of about 18 months, we were able to touch 7,000 people, over 7,000 people in West Baltimore, and enrolled 2,000 people into our hypertension program. As you can imagine, we were working with academic organizations, healthcare organizations, federally qualified organizations, as well as hospitals. It took a little bit for us to get our data use agreements up and running. But what was really great about the pathways was it really did set the foundation, allowed us to put in the infrastructure where we could really have a long-term impact on the community. So our goal was to enroll 2,000 people, and we've reached that goal, which allowed us to reapply for the Health Equity Resource Community Grant. One of the things we learned, next slide, was that when you think about cardiovascular disease, people in the community are also suffering at the intersect of mental health and the interconnections between mental health and cardiovascular disease. So our areas of focus for RICH 2.0 and the HERC is to address both of those issues. We work through self-monitored blood pressure programs. We believe that community members, when they're given the resources that they need, are able to help monitor their own blood pressure, and that's particularly helpful. And we also refer to support groups and behavioral health to address their mental health needs. We didn't want it to only be deficit-based. So often people think about communities from a deficit-based perspective. So we also wanted to focus on understanding assets. So for this project, we're also measuring hope as a mental health variable, with the thought that sometimes having hope can mitigate some of the concerns. We're focusing on all the social determinants of health, but for this project, we will particularly highlight food, transportation, and economic development. What we learned from RICH 1.0 was people really need financial capacity, and when they're given that, some of the other barriers begin to fall for them. So next slide, please. Our population is in West Baltimore. The real benefit of RICH 2.0 is that we've been able to expand and add 3 additional zip codes to the areas that we were already focusing on, and that'll be particularly helpful. This week, as I'm presenting to you right now, I can tell you on a personal note that addressing hypertension is so important to people that live in these zip codes. These are the zip codes with the highest hospitalizations related to cardiovascular disease. I lost my uncle just 2 days ago, 63 years old, to a massive heart attack. He lives in the 21229 area, and I think about this program, and if this program had been around a long time ago, so that people can address their hypertension and their mental health before it gets to the stage of really leading to a massive heart attack. We know heart disease is the #1 killer, and so I really do appreciate this committee and everything that you've done to support programs that reduce health inequities, particularly in cardiovascular health. That's a short intro to the program. I could talk a lot more about it, but I'm going to hand over so that we can hear about Interfaith Works.
Okay.
Thank you.
Thank you. And thank you for being here and for making a difference.
Thank
And
you.
if you see some of our members getting up, it's because they have some subcommittee work with different caucuses. Someone has AAA just came, so they had to go meet them. So, life, right? You're legislating, but you're living. But you have more than the majority here, so.
We're not offended. It's okay.
Yeah,
Thank you. Thank you for that. And thank you, as my colleague said, for this opportunity. I'm Liz Kruger. I'm the Director of Homeless Services for Interfaith Works. And for those of you who are not familiar with Interfaith Works, it's a Montgomery County-based nonprofit. And it has 6 different sites throughout Montgomery County, historically serving Montgomery County, but we are really excited to announce that through this grant, we've now been able to expand into Prince George's, and we will also be serving that community, and I'll talk a little bit more about that. But our primary focus at Interfaith Works is shelter and housing, essential needs, and then vocational services. Those are our community-facing programs and the bulk of our interventions. So we serve about 35,000 residents every single year through those 3 departments. And those 3 departments will comprise the Interfaith Works Better Health Coalition, which has been formed through this grant. And it is our hope to enroll thousands more that we're already serving into these extra supportive services and interventions with the goal of improving health outcomes and reducing health disparities. So the Interfaith Works Better Health Coalition will focus on multiple social determinants of health, but with a primary focus on housing, since it's already an intervention that we are offering. Access to social services, so this includes benefits from utility assistance, rental assistance, and other connections, employment and vocational services, and then basic needs such as clothing and food through our Essential Needs Center. So we, again, will be addressing.
You want us to move it?
What's that?
Do you have a different slide you want us to put up?
You want us to advance the slide?
Oh, yeah, I'm sorry.
That's okay.
Oh, you're moving on to
Yeah,
slides?
what you're reading, so I thought they might want to see.
Oh,
I'm listening and I'm reading.
I just
Moving
talk,
along.
so
Yeah,
you'll
that's okay.
never be able to find out where I am on any given slide. Drives my CEO
Friday
crazy.
afternoon during
Yeah. Yeah, my development chair always gives me stuff to read.
Yeah,
Yeah.
I was listening.
I'm like, I think she's on the next slide.
Thank you for looking at them. We'll be there in a moment, I promise. But I did want to mention that, again, while we will be focusing on health inequities, disparities, we will have a particular emphasis on behavioral health and substance abuse. That is definitely something that we observed through the pandemic, that acute behavioral health and substance dependence increased exponentially in the population that we're serving. So not only those experiencing homelessness, but those made vulnerable by poverty. This was empirically obvious that we needed better interventions and better partnerships to address. So moving on to the next slide, which we're already there, thanks to your astute observation, I want to talk about some of the partnerships in which we are embarking on these interventions. We have, as part of this grant, partnered with a behavioral health agency. They are called Pathways to Housing, not to be confused with the pathways done through these grants, but they not only offer supportive housing, but they have multiple behavioral health interventions, including an assertive community treatment team. So they will come and visit our community members and anyone enrolled in the Interfaith Works Better Health Coalition, wherever they are. They have a nurse practitioner offering medication-assisted treatment and pharmacological interventions. They have multiple peers, which we find a best practice intervention, particularly for individuals who are not quite ready to change, not quite ready to stop using, not ready to engage in medication and more traditional treatment as usual, as it's called, more traditional forms of intervention. So peer support services will be part of the ACT team, and helping people to engage and build relationships until they are ready to make changes from a harm reduction perspective. And then our other partner will be Kelly Collaborative Medicine, and they are already based in all our shelters and will be expanding to our other sites. They will work with anybody that we refer through the Interfaith Works Better Health Coalition. That includes the uninsured, which they can do with grants, and they will work, as will we, to get everyone insured and access to primary care and specialty services that they need. So we are able to take a very hands-on approach to the behavioral health and substance abuse needs, as well as the subsequent clinical outcomes with these really strong partnerships. You can see in the subsequent list, these are our existing services at Interfaith Works, which again include our emergency shelters and supportive housing programs, which we are now enrolling Prince George's residents into as well. That's been a long-standing need and wish of us, or wish for us in homeless services, I can tell you, because I think most are aware we're in a housing and homelessness crisis here in the country, certainly in our local communities as well. And, you know, Prince George's has had a dearth of shelters, so it's been a amazing opportunity through this diverse funding to be able to offer shelter to Prince George's residents and community members, and then be able to work with their county government to house them in Prince George's, so that they can be returned to Prince George's and maintain the residency there, but that we can assist along the way with supportive services. We have the essential needs, which and connections, which are a lot of prevention services, right? Someone mentioned earlier in the last hearing or briefing that prevention, philosophically, we as jurisdictions need to be moving towards more resources into prevention, and we believe the same thing. We need rental assistance and eviction prevention. Once someone is already homeless, the trauma cycle begins, and it can be very hard to help them out of it. So we are excited to be able to bolster our connections program, vocational services, getting people jobs, getting them long-standing jobs, getting them better wages. Our vocational team already has great results here, and we're really excited for this to be supported through the Interfaith Works Better Health Coalition. And then, of course, our Essential Needs Center has groceries readily available for families based on referral, and it will serve Montgomery County and Prince George's as well. And clothing. You can come in and get a lot of household items and clothing for the whole family once a week, actually. So it's one of our most popular services and really popular for families. So finally, we have a lot of clinical outcomes that we are hopeful we will be achieving. These are just a few of them. The first one is enrollment in primary care and in insurance. We will aim to get everyone who completes an intake into the Better Health Coalition in with a primary care provider. If they don't have one, Kelly Collaborative Medicine is ready to see them right away. And that is the strength of that partnership. We can send them immediately, and they can be referred to specialty services from there. And then, again, we within our case management structure or theirs can get them insured when eligible. We will be screening everybody for the social determinants of health and making referrals, accordingly based on where they are determined to be at risk. And then we have high hopes that some of the highest diagnoses we see in the population we serve are cardiovascular. They are diabetes, cardiovascular diagnoses, COPD. We have a lot of chronic pain and arthritis. So we are hoping to see improved outcomes with all of those. So we'll be tracking achievement of diabetic control, blood pressure reductions, and then really exciting for us, you had mentioned, Yolanda, HOPE being one of the measures you'll be tracking. We are going to also be tracking social connectedness, right? So we know that the Surgeon General put out the report on loneliness in the pandemic and the clinical outcomes associated. We also strongly believe and observe that a population and individuals that are disenfranchised from services, from resources, and from community deteriorate quickly. And so we will be to the social connectedness survey, which we will be administering along the way. is based off the UCLA loneliness scale, and it is a best practice measure to determine one sense of community, which is directly tied to their self-worth and can have longstanding health impact for them. So we will be not only connecting people to community and resources, but hoping to see that their social connectedness improves over time. So those are just a few of the things we're doing. I also could talk forever, and I know we stand before you and the and lunch. So
Thanks, Tiffany.
yes,
Thank you.
Appreciate you both.
And thank you for being here. And I know that, you discussed beautifully the work you do, which, it is really important because in those areas, a lot of people do not have primary care, right? And if you don't have access to a doctor, you cannot take care of those underlying illnesses you have. And in those particular communities, you have cardiovascular disease, right? The high blood pressure that is really a killer. I was also looking at the description of the other programs that you have, the other grantees in St. Mary counties, looking at chronic illnesses, and in Wicomico County, the project also looks at chronic health conditions, and it's actually with Title Health as well. So the diversity of the different awardees is really wonderful in the different counties, which is great. I'm going to open it up for questions. I know Delegate Bandari has a question for you. So Delegate Bandari.
Thank you. Madam Chair, Elenda, I'm sorry for your loss. Thank you for your team for wonderful work and the Impact Pro initiative. In your presentation, you said about some reporting measurable outcomes such as reduction in a hospital visit. This committee deeply care about the ER wait time. We passed the bill and we are working on it. We have the worst in the nation, 4 hours and some minutes, and you talk about some improved social determinants of health as well. So I'm wondering what strategy are you implementing to sustain these results beyond the grant period? And how are you engaging with the community to ensure their needs are continually addressed and we could scale up this program in other jurisdictions as well? Would like to hear your experience.
Sure. Thank you so much for that question. As you can see, these organizations have been committed. When you see it goes back to the HEZ in 2010, it's 2025, we're still working together. That gives you a clue that we have continued to work together unfunded. There's been gaps in there where we were not funded, but we continue to network together to work in the community. Sometimes we had external funding from different organizations like Robert Wood Johnson Foundation. Sometimes we were unfunded. I'm also the Dean for University of Maryland School of Nursing. We have a very strong community public health portfolio where we leverage nursing students and our nurse practitioners and nurses in the building. They do go out and help us to sustain community programs. And so sometimes we do continue without funding. As we know, we may be upcoming a very difficult funding period for grantees. So it's always good to know that we also have the assurance of being resting on some of the things that we have been able to do without external funding. So that's just University of Maryland. We also have University of Maryland medical system that's involved. We have nonprofit organizations like Roberta's House, BTST Care Services. All of us are committed to continuing services in West Baltimore. We do all of this work through self-monitoring blood pressure programs, as an example. Many of us have mobile health, like the Governor's Wellmobile or St. Agnes Hospital, which has a mobile health program, and we work with them to also deliver services. We also deliver services in places where people live. One of our partners, for example, is Community Builders, which are in senior facilities within West Baltimore. And so we go in to the senior facility building and we provide services in place, which is particularly important for people that can't get out. We do most of the work through a community health worker model, which I know there's been a lot of investment in the state for that type of model. And we're excited to have our community outreach workers that are from the community go out and address social determinants of health, and also link individuals to different social resources in the community, like housing and transportation and food.
Thank you.
Thank you for that question.
Thank you for the answer, Delegate Whitehammer.
Yes, thank you, Madam Chair, and thank you all for being here. This is truly wonderful to see the outcomes and the type of infrastructure that has been built related to these programs. And so, and I think you touched upon this just within your recent answer around the partnerships that you all have been able to build and continue to expand. But in speaking to that, I wanted to know how you all are thinking about sustainability. I know as organizations, you have to do it all the time to maintain your own operations and the like, but if you could just expound upon your thoughts about what does expansion look like? What does sustainability look like, given the climate in which that we're in, aside from government funding, but how are you all thinking about braiding and blending funding, which I know you do often in the other work in which that you do. But even beyond that, a lot of the social determinants of health that you had articulated and looking at those social and political, those structural determinants, recognizing that these are larger systemic issues. And so in addition to the braiding and blending of funding, how are you also mobilizing and engaging in some of these policy opportunities? You talked about, housing, right? And, some of these other sort of big issues, transportation and the like. And so wanted to know how that is also being integrated within some of these strategies as well, and how you're mobilizing community members to take action.
Sure. Thank you so much for that question. We're constantly looking for ways to sustain the program, both with external financial support, even though on the government level, financial support might be difficult. We do thankfully live in a country where we have a lot of philanthropists, for example, that are willing to contribute, especially when they see success of a program. An example of that would be because we were able to reach 7,000 people, even though we only enrolled 2,000, it's very difficult for people to trust within certain communities. And so you have to touch so many people just to enroll the 2,000 people. But because of that success in only a 18-month period, we have had external philanthropy organizations reach out to us and say, we want to be a part of sustaining this. And so next week, I'll be presenting, for example, to the Maryland Philanthropy Network, which will bring together philanthropists from across the state that are particularly interested in cardiovascular disease and mental health, some of which have already come forth to say, I'm interested, but please come and show us, tell us more. And then there's foundations like Robert Wood Johnson Foundation, to answer your other question, that has a current call for proposals around policy specifically, which would be really interesting maybe to connect with policymakers to think about that, because they're asking the same question as you. How can people in the community work with policymakers to be able to really support some of the health equity work that the Robert Wood Johnson Foundation is trying to do? So I think foundations like Robert Wood Johnson Foundation and other external philanthropists, above and beyond what we're still hoping that the government will be able to do, will help sustain the program. Did you want to add?
Yeah, sure. I can answer that from our perspective. So I would say that for Interfaith Works, the interventions pre-existed the grant, right? So the supportive housing, which we know improves health outcomes demonstrably, like getting them off the street, out of shelter, into housing, right? Like some of our critical interventions will persist because the funding is from elsewhere. And so I'm very confident that we can continue the work and meeting those needs. Where we would have to where we would struggle is to track it and to have the additional staff and support that is helping us to meet the actual needs of the Interfaith Works Better Health Coalition. So like the extra transportation and supportive services we are offering, we would need to look elsewhere for funding there. If this grant disappeared in 3 months, right, it would have an impact on some of those smaller interventions that we're running, but the larger ones are there. Now, ultimately, we have to stay very involved in advocacy, which we already are, because we can keep building shelters, we can keep, enrolling people into permanent supportive housing, but ultimately, if we don't stop the inflow, it's just we're in a hamster wheel. It's a cycle that it's a systemic disaster, right? So we actually, it's odd to be a place that runs shelters saying we need to ultimately phase out of shelters, right? Like if the system were working, there would be supportive services and prevention, and then all the way in the housing side, right? And you would move away from the emergency response. People shouldn't have to hit the street in the shelters before they're considered, to be eligible for services. So that's the philosophical shift that I'm talking about. We do advocate for that all the time. We're constantly in hearings talking about, where funding needs to be trickling and where our priorities need to be. But that takes political will, so I don't need to tell anybody here. That's a whole other thing. But so I have a lot I could say about that. But we do advocacy is critical to what we do as well, because we don't want to keep doing the things we're doing forever, right? Yeah.
Right, thank you, Madam Chair.
This committee prevention for the work we do here, right? Like you have to spend at the beginning, right? In education, prevention, so that later on it doesn't become a chronic illness, and it's more expensive at the end.
It is.
I don't see any other questions, but I do have to say on behalf of the committee, I want to thank you for coming on a Friday afternoon when it's not easy to come to Annapolis, find parking, go through security. I often say that because it's a lot of work. But thank you for the work you do, because especially during these times where, so many people are struggling, right? And we're trying to help, right, with the programs we have at the state level to help those that need it the most. I think that funding is going to be pretty limited, right, at the federal level. And unfortunately, you guys are going to be the ones that people are going to look for, right, when we don't have enough in programs. So I want to thank you for the work you're doing, and I want to thank you in advance for the work you're about to do for the next 4 years, because your work is needed, okay? And I want you to feel appreciated. So thank you for coming to our committee. Our doors are always open to you. And Mark, thank you for your good work and your team, okay? I hope you have a blessed, wonderful afternoon.
You as well. Thank you all.
So this, for the committee, concludes the briefings for the afternoon. Now, for real, I hope you have a blessed weekend, okay? Take good care. Bye-bye.